Can we go ahead?
One 24 participants.
So should we start?
Yes.
So good evening to all the participants, and we are starting the our fourth and the Mumbai fourth webinar on from the Mumbai ISPEN branch and the 19th webinar from the ISPEN, and we welcome you all to the very good topic, which is the role of soluble fiber in the ICU. So for today, I am the Dr. Jairam from the SL Raheja Hospital. I am the consultant there, and I am the chairman of the Mumbai Spain branch. So uh, kindly attend this webinar as a whole because it is very it is very useful webinar for the ICU people to have a good knowledge on this. And if you have any query, you just put the your queries in the chat box, so it will be answered at the end of the session. So this webinar have a speaker of Dr. Akhilesh Tandekar, and it is moderated by Dr. Vedei Amok, and the expert panelist will be Dr. Sanjit Sachidharan. He is the director of the critical care at Raheja Hospital, and he is also president of the ISPEN. So, moving ahead, so I will introduce the Dr. Vaidehi Amok. She is the chief dietitian at the Bhakti Vedanta Hospital and Research Institute. She has a wide experience of more than 2 decades in the field of clinical dietetics and applied nutrition. She is also certified diabetes educator and nutrogenomic expert. Her main area of interest are preventive nutrition, approach along with the management and reversal of different clinical conditions. She also conduct corporate workshop on diet and lifestyle management. She also hosts a diet recipe program on the TV channel. She also invited as a guest in dial-in program on All India Radio. She is also a leading she is also columnist in leading Marathi newspaper and Indian Express Group. She also have live talk shows on diet and diabetes, arthritis, memory, pregnancy, obesity in drama theaters. She is also active participant in school nutrition workshops. Over to you, Vede.
Uh, Thank you so much, Dr. Jairam, for your kind introduction. Very happy to be the part of this seminar and very proud to introduce today's speaker, Dr. Akhilesh Tandekar, sir. He is a head consultant, critical care, Vokar Hospital, Mumbai. He has a wide experience of more than 2 decades in the field of critical care. He's a professional intensive care consultant with in depth ICU management skills. Advanced critical care, he's teaching DNB students, especially in the subjects of heart, liver, and lung transplant. He is a faculty for national and international critical care conferences. And also, he has various publications under national as well as international journals. His areas of expertise are critical care, transplant, trauma and disaster management, cardiac critical care, heart transplant, neurocritical care, pain management, ICU setup, and setting up the ICU protocols, etc. So, very happy to have you, sir, on the panel today. And looking soluble fiber is something basically for us as a nutritionist, soluble fiber, but overall fiber is very a nutrient very near to our heart as a dietitian also. So, looking forward to learn your expertise. Thank you so much.
Thank you, Dr. Vedi, for this introduction, and thank you, Dr. Jairam, Dr. Sanjeev, you are here as expert panelist. Today we are going to discuss this important topic of fiber, use of fiber in the intensive care and its application as a nutritional value. We have seen fibers, have been recent addition, but it has been popular since a decade or so, but the popularity was undermined, and it has never been given that much importance compared to what the other nutritional therapies are concerned. It has been given a lot of emphasis, like we give a lot of emphasis to calories, a lot of emphasis to protein requirement, supplementation, and all that. We had, had a lot of discussions on other micronutrients and macronutrients as well. But these fiber-related discussions are very less, and that's why we have had a discussion amongst all our clinicians that we should have some discussion on this particular topic. So the fiber diet, addition of fiber has definitely a nutritional value, but it has been less focused over a period of time. We have seen we give a lot of emphasis to other nutrients, but the fiber is the nutrient which is most neglected, but it has a great necessity as far as the nutritional requirement and the supplementation is concerned. It has a great value. As far as the reduction or disease control of the disease process is concerned, it has some immune modulation action. It also has prevention of different illnesses also, and its deficiency can definitely lead to a lot of problems related to the GI, especially diarrhea. And we will also see in this discussion how we can utilize this fiber in appropriate amounts and when to add this fiber, whether the fiber has any significant value as far as the nutritional supplementation is concerned. And we'll see how patients improve with addition of fiber. And it's not just the clinical recovery from a disease condition, but it is also important that the patient should be discharged with a good quality of life. Okay, so we as clinicians probably we look more broadly at the clinical recovery, but the nutritional recovery is something which is probably undermined. And I would like to focus on these important issues or how we can improve the quality of life that I will try to emphasize in my slides. So as we know, this fiber is nothing but the remnant of the parts of the edible part of the food. And it doesn't get digested and absorbed, or if it is absorbed or digested, it is digested at a very significantly lower levels. And this dietary fiber term was coined, way back in 1950s. Okay, but the usage of this fiber and addition of fiber in the diet was really not had been, significantly emphasized by the clinicians. The role and its efficacy was really not studied well until we had good literature and recent publications which have shown that addition of fiber has definitely a good value as far as patient's recovery is concerned. So as we see from Indian perspective, let's not focus on the Western perspective and see the Indian perspective. We get fiber from various other food ingredients, right from the grains to the fruits and the vegetables. But most of these grains also lose fiber when the grains are polished, like the wheat and the rice. When it is polished, the fibers are lost. Even the vegetables, when it is overcooked, it loses its fiber. And the fruits, the processing of the fruit is responsible for loss of fiber. And we end later on with the deficiency of fiber in the diet, which is not measured or which is not calculated. We don't have significant tools to really measure the fiber deficiency. It has to be monitored clinically. And the clinical response can help us to identify the replenishment of the fiber But like proteins and calories, we can calculate by different means. We have indirect calorimetry methods, and we have other assessment tools, but deficiency of fiber and its measurement and calculations are difficult. But I think we have some experts. They can also throw some light on measurement of the dietary fiber, uh, you know, uh, from the human body. And then majority of the population in India, we are at least more than 60 to 70% of the population is facing a deficiency of the dietary fibers. And we as a clinician have a significant role to replenish this deficiency and bring awareness amongst the clinicians and the common population that the supplementation of the fiber in the diet has a significant importance. So if you see from the ancient era, various sadhus and laureates, they and yoga and a lot of yogis, or in Ayurveda, there has been significant emphasis on the fiber. But in scientific world, we have seen that it was undermined, and probably there was a lot of emphasis on proteins and fat and other calorie calculations and the micronutrient and macronutrients. So there has been different research publications and the studies which have shown that the dietary requirement of the fibers should be as high as 10 to 20 grams to as high as 40 to 60 grams even. So the different guidelines have come up with the recommendations for the dietary intake of the fiber. And most of these guidelines have been derived from the Diabetes Association, because the core foundation of addition of fiber was, understanding the absorption of the glucose from the intestine, and how the insulin makes a lot of difference, as far as the glycemic control is concerned. So basically, these fibers have a significant role in maintaining euglycemia, or it will also prevent hyperglycemia, and insulin resistance can also be prevented. And simple addition of fiber can prevent the diseases like diabetes. I will show you in my subsequent slides. So if you see these recommendations, like, American Diabetes Association and the Research Society of Study for Diabetes in India, and even ICMR have come up with the recommendation that 20 to 40 grams per day of consumption of fiber will prevent different disease states, and it will maintain the gut integrity, and the health of the individual can be maintained. And simply addition of fruits or vegetables or whole grains can replenish the deficiency of the fibers. And when we see the traditional Indian diet, okay, the traditional Indian diet is a rich source of fibers, which can be in the form of the green leafy vegetables or pulses, like grams and other fruits. These are the rich source of fiber. And nowadays we see, there is a shift of dietary habits from the fiber diet to junk foods. And that's why we have seen our population having deficiency of the fiber. But I think if such recommendations are followed diligently, the deficiency of fiber can be avoided, and the different disease conditions can also be controlled. So as we see the physiology, so you will ask me, I mean, does it really have any significant physiological implications? Yes, definitely. As far as the effect of these dietary fibers are concerned, it is important in maintaining the postprandial hyperglycemia. So how does that postprandial hyperglycemia is controlled? So these fibers, when it is added in the diet, it delays the digestion and the absorption of the carbohydrates. So these are complex carbohydrates like starches, or cellulose. These are not absorbed, but it helps the absorption of the other nutrients. Okay. And when this fiber is added to the diet, it increases the bulk of the food, and it also leads to more satiety. So patient will always, or the individual will always feel that he is full. He will never feel hungry, and that's how the weight reduction can also be one of the parameter that can be the weight control can be achieved with the addition of the fiber. So the other mechanisms for control of the sugars is these fibers doesn't get absorbed or digested, but it gets fermented when it reaches colon. Basically, the absorption and digestion happens in the small intestine. But as it doesn't get digested and absorbed, it gets fermented in the large intestine, where this the byproduct of the fermented fiber is short chain fatty acids. And then these short chain fatty acids are responsible for maintaining the gut integrity. So it has some anti-inflammatory actions, by maintaining the integrity of the epithelium and the immune cells that are responsible for maintaining the gut health. So that is also well maintained. So short chain fatty acids are responsible for maintaining the gut immunity. See, other advantages of dietary fiber it has some hormonal advantages. So as we know that when the fiber diet reach intestine, the gastric emptying is delayed, and the macronutrient absorption may be reduced. So as it increases the intraluminal viscosity of the content, it increases or it delays the gastric emptying time, and the insulin which is supposed to be released immediately, it gets delayed. So sudden rise in sugar due to the deficiency of the fiber is prevented. And when there is sudden rise in the sugar due to excess glucose absorption, when there is a deficiency of the fiber or the diet deficient fiber is given, so the glucose is absorbed from the intestine and there is sudden rise in glucose levels. And due to this sudden rise in glucose, there is sudden rise in insulin. So large amount of insulin is released immediately, and then due to the sudden release of insulin, later on the patient will have a hypoglycemia. So it's not just the postprandial hyperglycemia, but later post-absorptive hypoglycemia can also be prevented, and the sugar can be controlled. So the other advantages of the fiber is maintaining the colonic health. So as the fibers get fermented and the byproducts are short chain fatty acids, it reduces the hepatic glucose production and it also reduces free fatty acid generation. So that's why, so by adding fiber, the insulin sensitivity is increased, and the glycemic control is better off with addition of the fiber. And as I've already discussed, when there is increase in satiety, patient will eat less and he'll consume less fat, and that's why the weight can also be controlled. So these fibers are available in different forms, So out of which the soluble fibers are, so these are the partially digested fibers, in colon, whereas insoluble fibers doesn't get digested at all. So these insoluble fibers are complex carbohydrates like starches, cellulose. Okay, so whereas these soluble fibers are in the form of gorgum or other elements which controls the lipid profile. Okay, so as it prevents the fat accumulation, so the cholesterol is also better controlled with soluble fibers, and as it forms the bulk, bulk of the absorbed food, it promotes later on the absorption of the water from the large intestine is also well maintained, so that the stool consistency is well maintained, and it also promotes the peristalsis. And that constipated patients are the beneficiaries with the soluble fibers. And even insoluble fibers also promote peristalsis, and it also forms the bulk. As we see, the fibers not only delay the gastric emptying, but it forms a gel-like consistency of the contents in the intestine, And when the short chain fatty acids are, produced as a byproduct of fermentation, so it reduces the overgrowth of pathogenic organisms. And then that's why, the absorption is also better and the gut integrity is well maintained, and peristalsis of the bowel is also well maintained. So one of these soluble fibers is resistant maltodextrin, which is fermented in the colon, and it produces short chain fatty acids. As these short chain fatty acids, and this resistant maltodextrin, 50% of it remains undigested. As it is a soluble fiber, only 50% is undigested and unfermented. And that's why, it being not digested and unfermented, it absorbs more and more water from the colon, and the stool volume is well maintained and the constipation is prevented. As I've already discussed, the short chain fatty acids also maintain the flora of the intestine, and it improves the peristalsis, and that's why this relieves the constipation in constipated individuals. But this may not be very beneficial if the patient has autonomic dysfunction, uncontrolled diabetes. These patients have autonomic dysfunction. So it has to be used in caution, especially for those patients. But as we know that it has some prebiotic efficacy, it is very good for diarrhea, especially when you have antibiotic associated diarrhea, as it maintains the consistency of the stool, and absorption of the water from the colon is quite enhanced. The stool consistency is also maintained, and the diarrhea is also prevented, as it maintains the bulk of the content in the colon. And as we see the different benefits of soluble fiber, it is very essential to maintain the gut health integrity. So inflammatory bowel disease patients, where the peristaltic movement is affected, and it has all inflammatory reaction going on, as far as the epithelial and the immune function is concerned. There is dysbiosis. So soluble fibers has a significant role in inflammatory bowel disease, where the absorption and digestion can be enhanced with the help of fibers. And as far as the metabolic syndromes are concerned, like diabetes, and the absorption of other micronutrients are concerned, so this absorption of micronutrients is enhanced. So the deficiency of these micronutrients can be prevented by addition of the fiber. But yes, as far as the control of diabetes is concerned, or the insulin requirement is concerned, soluble fibers can be the best addition to control uncontrolled diabetes even. And for diarrhea, as it maintains the stool consistency, the diarrhea can also be prevented. How does the fibers play an important role in the ICU? So it has many significant advantages, especially, patients with, electrolyte imbalance. A lot of electrolyte imbalance is due to deficiency of the fiber, because most of these elements are lost. With the addition of the fiber helps in absorption of many electrolytes, especially potassium, calcium, even sodium. These elements can also be absorbed. And it also maintains the absorption of the food and essential elements which are required. That absorption is also maintained. So as we know that patients in the ICU, they receive a lot of broad spectrum antibiotics. And then antibiotic associated diarrhea is one of the mess in the ICU, and control of diarrhea is very difficult. Okay, so in that situation also, whenever there is a diarrhea, so there is inflammation of the bowel. So the starches, after fermentation, the short chain fatty acids are released, and short chain fatty acids also produce, and these maltodextrin, like other soluble fibers, produce butyrates. So these butyrates maintain the gut immunity, and immune inflammatory response is controlled. So the most important role here in these patients will be to maintain the inflammatory reaction, control that inflammatory reaction, maintain the epithelial layer, because in critically ill patient, there is bacterial translocation of the organisms from the gut, and it is responsible for multi-organ dysfunction and organ hypoperfusion. So addition of fiber can prevent these issues, and the inflammatory process is also controlled. The inflammatory process which is happening at the GI tract is well controlled with the fibers, and bacterial translocation can also be prevented, and the patient can also be fed because GI intolerance is also prevented with addition of the fiber. So 10 to 20 grams of fiber daily, if you add it, I think that can prevent a diarrhea in patients in the ICU, for the patients in the ICU. So there are prospective randomized trials which have shown that so addition of fiber can prevent the frequency of diarrhea in the ICU, and that is well controlled with the fiber treated diet. And if you add the fiber in the diet, the diarrhea which is responsible for increased length of stay in the ICU or increased ICU mortality is very well controlled. So this prospective randomized trial of 120 critically ill patients, it has shown that those patients who are treated with the diet with fiber rich diet containing fibers of around 15 grams controlled compared to those patients who did not receive fiber, they have been benefited, and their ICU length of stay and morbidity and mortality was reduced. So it's not just the immune enhancement, it's not just the sugar control, or it's not just the control of diarrhea. Beyond that, it has a significant impact on reduction of morbidity and mortality. So that's why I think probably the fibers addition of fiber in the diet should be given a lot of importance, especially in the ICU. So as we see, these fibers contribute significantly in critically ill patients by maintaining the nutritional status of the patient. It should be one of the addition along with the calorie and fats and proteins and the carbohydrates. The fiber addition of fiber should be given a lot of importance. And we know that in ICU the patients are critically ill, so addition of fiber can lead to improvement in morbidity and mortality, and length of stay is reduced. And studies have shown that once the patient gets admitted in the ICU, so the deficiency of these short chain fatty acids, starts, immediately after the patient, becomes sick and they are admitted in the hospital. And some studies have shown that the deficiency starts within 6 hours of admission, and the replenishment takes, weeks together to replenish the fiber related deficiency. So that can be as high as 6 weeks. So if you preemptively start adding fiber in the diet, so the deficiency will be prevented, and the deficiency which remains uncontrolled for weeks together can also be controlled. So there are some other indications of fiber, addition of fiber, especially in patients with the, those patients who have constipation or ileus post-surgery. So we often use these laxatives, and laxative abuse is responsible for diarrhea, even post-operatively, or if the patient is in the ICU and critically ill. So the laxative overuse is responsible for diarrhea and volume shift, and these patients become dehydrated. So simply addition of fiber with just prokinetics can prevent this diarrhea and the volume loss that happens due to diarrhea, and the electrolyte and the bicarbonate loss that happens due to diarrhea can be prevented. So metabolic issues can be sorted out, metabolic acidosis, hypokalemia, or magnesium deficiency can be prevented by addition of fiber with just prokinetic agents. And then studies also have shown that in patients with the GI surgeries who have received fiber, so these patients have been able to pass the flat test sooner than those who have not received the fibers. And that's why the overall length of stay has been reduced in patients who have been operated for GI surgical procedures. And, we have seen patients who undergo GI surgery, they stay in the ICU or in the hospital for a long time. It is just due to the ileus and the bowel dysfunction. So this bowel dysfunction can be prevented by addition of fiber. So as against the role of fiber in the sepsis is concerned, this some studies have shown that this addition of fiber is responsible for reduction of ICU length of stay by almost 9 to 10 days. So the overall burden and the cost related to the treatment can also be avoided by simply addition of 15 to 20 or 30 grams of fiber, and the patient's overall length of stay in the ICU or the hospital can be prevented. Some meta-analysis, including 21 studies, over 2,000 patients have analyzed, and in these patients, the hospital length of stay was reduced by 3 to 4 days, simply addition of fiber. And those patients who received fiber-free formula had significantly increased length of stay. So the dose required, in these study, the dose of fiber that was supplemented in the diet was around more than 20 grams. And simply just addition of 20 grams of fiber per day was responsible for reduction of length of stay in the hospital by 3.6 days, 3.16 days or 4 days is significant. And I think this should be given a lot of importance. So as far as neurosurgical patients are concerned, these patients also have a lot of, glucose, shifts. And then the glycemic control can be achieved with addition of fiber in these patients, and then as we know that glucose is responsible, or hyperglycemia is responsible for secondary brain injury, and then control of sugars is of paramount importance, especially in the neurosurgical patients or neuro patients, stroke or traumatic brain injury patients, and post-neurosurgical patients. The glycemic control is very important, and glycemic control can be achieved with addition of fiber. And, some small studies which have been published, it has also shown that those patients who have received fibers, their insulin dosage requirement has reduced, and then the reduction in overall blood glucose level was also achieved by addition of fiber, which has a prebiotic efficacy. So how do we improve the tolerance of how do we improve the tolerance of the food? The tolerance of the food can also be improved by just addition of the fiber. And resistant maltodextrin and other guargum and acarbose are also available. So the dose of hydrolyzed guargum can be around 20 to 40 grams, and resistant maltodextrin, the dose can be as high as 50 grams, and it can maintain the tolerance of the food. So what about the role in the opioid? As far as long-term usage of opioid is associated with tachyphylaxis, and these patients become constipated later on. And these fibers can have a peripheral action on the gut, and it can have a mu receptor antagonistic effect. As far as these mu receptors are concerned, these opioids act on mu receptors, and mu receptors are responsible for gut dysmotility or reduced motility of the bowel. The fibers can act on these mu receptors, antagonize these fibers, and can maintain the peristalsis. And overall, the ileus can be prevented by addition of fiber. So the other strategy in opioid-induced constipation is to change opioids, from morphine to oxycodone, and there are other opioids which are available. We have to change opioids. Probably cycling of opioids can also prevent constipation, but addition of fiber has more impact in control of constipation compared to the cycling of the opioids. So as far as the role in GI diseases are concerned, ISPEN has recommended the dose of soluble fiber of around 10 to 20 grams. And, it is sufficient enough to control diarrhea in patients, who are critically ill. And fiber is also responsible for maintaining the GI tract digestive and absorptive capacity is concerned. It maintains the digestive and absorptive capacity as it maintains the immunity of the bowel and the epithelial integrity is maintained. So digestive and absorptive capacity is also well maintained. So as we see the benefits of fiber, not only in the GI tract, but overall, fibers are also responsible for reduction of chronic heart diseases. So as we see, fiber deficient diet is associated with increased lipids and cholesterol, and atherosclerotic diseases are common, and that is responsible for myocardial infarction, stroke, and even atherosclerosis is also responsible for uncontrolled blood pressure, hypertension, and diet deficient fiber is responsible for insulin resistance and diabetes. And as we know that obesity is also responsible for deficiency of, so the obesity is the result of deficiency of the fiber. And inflammatory bowel diseases is one of the indications for addition of fiber. So these patients are likely to be at a lower risk of developing, diseases like stroke or cardiovascular diseases. So as we see these, the role of fiber in the inflammatory bowel disease. So this maltodextrin, which is called as resistant maltodextrin, it's a soluble fiber, and it increases fecal, non-pathogenic bacterium, which is bifidobacterium, and it produces butyrate. And this butyrate is an important energy source for colonic cells, and it has shown anti-inflammatory properties. And then this resistant maltodextrin leads to increase in butyric acid concentration, and it is beneficial, for the colon and the small intestine also, for maintaining the integrity of the bowel. And these are some of the recommendations by ISPEN and FDA and ICMR and different dietary societies. Most of these societies have recommended that the addition of fiber of around 10 to 20 grams is sufficient enough to maintain the gut integrity, prevent diarrhea, and insulin resistance and diabetes can also be prevented, and GI tolerance can also be enhanced by addition of fiber. So as we see, fiber has a significant role. So to summarize, fibers not only maintain the gut integrity, but it is responsible for overall morbidity, reduction in morbidity, mortality, decrease length of stay, and the absorption of micronutrients and macronutrients can also be enhanced with addition of fiber. So my emphasis will be like, if the expert can also add on the importance of fiber in the diet, I would like to hear from the experts also. But which the fiber, the role of fiber which was undermined, I think we as a clinicians and dietitians have a major role, to bring awareness about the importance of fiber in the diet, not only the critically ill patients, but even in our day-to-day life, the addition of fiber has a significant role. So in the diet, it is very important that the fibers in the form of vegetables or fruits can significantly prevent a lot of cardiovascular diseases and different diarrheal illnesses and different GI-related illnesses can be prevented with the soluble fiber. With this, I would like to conclude my session and would be happy to be involved in the discussion with the panelists also. And I would like to hear from Dr. Sanjit. He is an expert in the field of clinical nutrition. Dr. Sanjit, if you would like to add a few important points, I might have missed a lot of important points. Sorry for that. If you can add a few important points, that will be of great help. Over to
No,
you.
I think, Dr. Akhilesh, it's been a wonderful presentation. I think you've gone through the entire spectrum that comes with respect to fiber. I think we've been dealing with fiber for the last 300 odd years, and right from Hippocrates, who said that fiber is something that is responsible for the gut to be more healthy than otherwise. I think you've covered almost everything there. I think what we should do is, if the moderator agrees, is we should go and take up some questions that if there are any. Dr. Vedi, over to you.
Yeah. Thank you so much, Dr. Sanjit. Dr. Akhilesh, it was such a wonderful presentation that I was thinking, okay, this part may be covered, this may not be covered, but you have actually covered each and every point. So I had a couple of questions in my mind, but you have answered without asking them. Just one point which I liked a lot, what you mentioned before we take up the questions, that you mentioned the quality of life. Like we at this side of the bed, we are aware that okay, electrolytes are getting deranged, or patient is having high creatinine and whatever it may be. But from the patient's point of view, quality of life is just today I am having constipation or today I have got diarrhea. And as a dietitian, I am aware that if these two things are patient is suffering from, then irrespective, even though he's improving clinically as per our understanding, that nutrition intake goes down, and unfortunately the hospital stay gets increased. So fiber definitely, especially the soluble fiber, definitely has a wonderful role to play. Thank you so much, Dr. Akhilesh, for a wonderful presentation. So we will take up the questions. I will just read out for you. um, okay. The first question asked was, 1 minute, huh? Okay. My doubt is, we restrict fiber to diarrhea patient. So how come soluble fibers are useful to diarrhea? So one of the attendees have asked this question. So can you answer this?
Yeah, so as we know, the factor responsible for diarrhea, one of the factor is the GI mucosal epithelial barrier is also lost. Okay, the integrity of the bowel is lost. The bowel is not able to absorb the diet or the food. Or sometimes we take food which has higher, osmolarity, and the food is not absorbed at all. Okay, so that's why it draws a lot of water, and with that, different disease states like antibiotic associated diarrhea, or if the patient is not eating well for long time, so the bowel integrity or epithelial layers are sloughed off. So that's why the absorption is affected. So by addition of fiber, the absorption of the nutrients is well maintained, and these fibers are not digested. Okay, they remain as it is. So when it remain undigested, unabsorbed, it absorbs more water. So the consistency of the stool, which is very thin, it makes it more like a slime. Okay, and the volume of the stool or the bulkiness of the stool is maintained, and then that's why the diarrhea is prevented. Second, addition of fiber also maintains the immunity. It maintains the epithelial barrier, okay, where the bacterial translocation is happening, that is prevented. The food stays in the bowel for long time, so there is more time for the absorption of the important ingredients from the diet, so the nutritional value is enhanced, and the stool consistency is maintained. It reduces the motility of the bowel by staying in the bowel for long time. As in diarrhea, the bowel motility is increased. So by addition of the fiber, the food stays in the bowel for long time. So that's why the motility also is reduced, and the consistency of the stool also improves. When the fibers are added in the diet. So that is what I can explain. Dr. Sanjit, you would like to add anything on that?
Yeah, I mean, you've answered most of it, but I'd like to add something more to this. Now, what happens usually in diarrhea is the fact that you are not able to hold the water. This is exactly what's happening. I mean, this is the simple thing. When you have diarrhea, you just can't hold water, and water just moves out of your colon. Now, what does a fiber do? Fiber does a few beautiful things in the colon. It doesn't reach and doesn't really get digested, so it reaches the colon. When it reaches the colon, any kind of fiber, let it be soluble or insoluble, it actually stimulates something called as the ileal brake. Now, what is the ileal brake? It actually causes a reduction in the gastric emptying, and it increases the small bowel transit time. This is what it does. So an ileal brake is responsible for decreasing gastric emptying, increasing small intestinal transit time, and that's why the whole gut gets delayed. Since the whole gut gets delayed because of the presence of a soluble or an insoluble fiber, the frequency of stools would actually come down in the first place. Second thing, as Dr. Akhilesh clearly mentioned about the fact that these kind of fibers would hold the water, it will hold the water, and thus it will improve the consistency of the stool. Now, what is important here that we must understand is that which is the fiber that will probably work in this case. It can't be all the fibers. It's not possible that all the fibers will do that, because we know fibers can work both ways. It can work for constipation and it can work for diarrhea. Now, when we talk about fibers, there are two varieties. One is the fermentable and the other is non-fermentable. Okay, first of all, it is clear that the fermentable fibers are the ones that will be fermented into the short chain fatty acids, which will stimulate the uptake of water and electrolytes. So you need to have acetate, propionate, butyrate, all of these things to stimulate the uptake of water and electrolytes. And these are the short chain fatty acids that will stimulate water and electrolytes. So A, we need a fermentable fiber. Second thing is, when they actually looked at whether it has to be viscous, or I mean soluble or insoluble, what we know is that soluble fibers are the ones that will actually be better. And why is that so? Because soluble fibers, they have a kind of soluble fibers are responsible for actually increasing the water content. Soluble fibers, it will actually make the stool consistency as gel. So soluble fibers are something that you want to take. Now, in these soluble fibers, there are so many other things. Psyllium, there is beta glucan, there is guar gum, there is pectin, there is inner P, there is fructooligosaccharides. There are so many soluble fibers that are. So which of these soluble fibers will help? Only those soluble fibers that have got very high fermentability, because we want their short chain fatty acids to come out, and those that have got very high viscosity. These are the only ones that will actually help in such cases. And one of the few things that does that is PHGG, which is also called as partially hydrolyzed guar gum and resistant maltodextrin. Psyllium will not going to work. Psyllium is isabgol. Isabgol is not going to work in such cases. You will need to give soluble fibers that are highly fermentable and with a high viscosity. And the one of the few fibers that is there nowadays in that is available is resistant maltodextrin, and the other is actually partially hydrolyzed guar gum. Not only that, as one of the important things that Dr. Akhilesh also mentioned, is it actually makes the colonic tight junctions more tighter, and that leads to better outcomes, for those fibers that are there, because it makes it tighter, allowing preventing even gut translocation of bacteria and thus reducing sepsis per se. So this is probably a take on which kind of fiber you should use among all the fibers that are there, because there are so many fibers that are there in the market as of now.
So the impact of fiber is, right from oral cavity to the colon. Okay, if you see the fiber, in our diet, consider it as a diet, not the artificial products. Okay, if you eat the fiber diet, you have to chew fiber more often. So when the food is chewed more often, there is more addition of the saliva, and saliva itself is important for digestion. So when the chewed food, saliva rich food reach small intestine, so it stays in the small intestine for a long time. Okay, and thereby it allows the absorption of majority of the micronutrients and macronutrients and lots of electrolytes, which anyways would have got lost. Okay, and we end up supplementing these elements, you know you know like anything. So the absorption of these micronutrients, macronutrients is enhanced. On top of that, this food stays in the intestine for a long time, Not only the absorption and digestion is enhanced, but it also maintains the movement of the bowel. So with lot of electrolytes, deficiency, potassium, magnesium, bowel remains in state of ileus. It doesn't move at all. Okay, so these fibers, they stimulate the intestine. Okay, and that's why the movement is enhanced. And when the patient has diarrhea, the short chain fatty acids and other elements, okay, they slow down the movement of the bowel by staying in the intestine for a long time. And then the short chain fatty acids, which are the byproducts of the fermentation of these fibers, is actually has an important role. If the fiber at all is contributing, to the gut health, it is all through the short chain fatty acids. The other effects are indirect effects, but the direct effects of fiber is through short chain fatty acids. That is what I would like to add about fibers.
Great. So I think Dr. Sanjeet and Dr. Akhilesh, both of you have mentioned right from prevention till the treatment, how the fiber plays the wonderful role. Nice. I will take up the next question. Do we interpret the enteral feed in ICU if patients are associated with diarrhea, or should we add soluble fiber in the RT feed, and how many grams are recommended?
These soluble fibers can be added in dietary nutritional supplement through different means. It can be added in water, it can be added in the formula feed, it can be added with soft drinks, it can be added with the juices, it can be added with the milk, it can be added with the even the food item. Okay, that if the patient is able to take orally, it can also be added. And the best effects of the fiber or the soluble fiber is seen with the dietary supplementation or supplementation in scientific nutrition is at the range of around 20 to 40 grams. Okay. So, but we still are not sure how much is the maximum dose that is going to be beneficial. But the range is between 20 to 40 grams. The sachets, the soluble fibers are available in the form of sachets. Okay, one sachet containing 10 grams. The 10-gram sachet will contain 9 grams of the resistant maltodextrin. Okay. And these sachets can be given twice or thrice a day, maximum up to four times, means 40 grams of soluble fiber is sufficient enough to control diarrhea, control constipation, maintain absorption, digestion, and also to maintain the gut integrity and prevent sudden surge in hyperglycemia or post-absorptive hypoglycemia and insulin resistance. So these all things can be prevented. If the fiber is added in the diet at a dose of around 20 to 40 grams. I mean, Dr. Sanjit may differ. I mean, if he's adding more than 40 grams, I would like to hear from him. So,
Before we actually go into the dose, a few important things is in ICU environment, the diarrhea is 99% not related to feed in the first place. There is many other causes for diarrhea when it comes to intensive care unit, and it might range right from you giving some drug which is causing diarrhea, like for example an antibiotic, like for example a magnesium, like for example a K-sol or a K-max syrup that is on any of these cough syrups. There are so many causes for diarrhea, and I think the first primary thing when it comes to diarrhea in an intensive care unit should be to eliminate those causes first.
yeah, I
I'm not
agree.
very certain. I'm not very certain if you were to do a fiber diet and try to hope that that will change, because that's what normally occurs. In an average intensive care unit, the moment the patient has got diarrhea, you just call in the dietitian and say increase the fiber in the diet. It doesn't work like that. So if the person has developed diarrhea, the first thing you notice, you try to figure out as a doctor at least, or as a dietitian if you're there on rounds, is to see the chart. Most often there would be something like a lactulose that was given. Most often there will be the situation where somebody has given an enema in the night and the diarrhea is persisting in the morning, or most probably there will be an antibiotic associated diarrhea. Very less often can you alter the diarrhea with an immediate solution like a fiber. A fiber is not going to work like magic. it's going to take its own time. So you cannot expect that tomorrow I'm going to put fiber and by the very next day the stool becomes normal. That's not going to occur unless you eliminate the causes, which are dime a dozen when it comes to intensive care unit.
Yeah, I agree with you. You add fiber only when you have corrected the problem which has led to diarrhea. Please, I should give you, I mean, everyone that this message is important. So just simply adding diarrhea but not treating the primary cause which has led to diarrhea will be a disaster or catastrophe. So
And
that's
that
why
is when
as
that is when the dietitian gets blamed for it, or the clinical nutritionist gets blamed for it, or the diet gets blamed for it, saying that this is what they don't know what to do. They're just causing diarrhea. It's not really anyone's mistake. It's the mistake of someone who's written the wrong order on the sheet usually.
but it is
And
also important, but it is also important, you have corrected the primary problem and all that. Majority of the patients who are critically ill, they have some or the other, issues, whether electrolyte, metabolic, or different disease states. But beyond that, also, if you see, there is a deficiency of fiber, which starts right when the patient becomes critically ill. And when patient present to us, they are already so much sick that they have all sorts of deficiencies, right from micronutrients to macronutrients, the calories, proteins, all the deficiency already has set in. So simply adding fiber may not help. You will have to also supplement the other nutrients also. So, but fiber, addition of fiber in the diet for those patients who have nutritional deficiency should be a priority. That is what I can recommend or suggest at this point of time.
can I add some?
Don't forget adding fiber in the diet. If you are adding proteins and fats and
Agree.
carbohydrates, please add fiber also in the dietary
Uh,
supplements.
I would just like to add something like, as a part of one of the nutrition protocols, apart from deciding whether 20 calories or 35 calories per kg body weight and protein 0.07 to maybe 2.1 gram per kg body weight, we also have made it mandatory for our ICU patients to add the soluble fiber ranging from 15 grams to 30 grams when patient is on the enteral feed specially. So rather than waiting for the diarrhea to set in, we before that we add. And it is not only the commercial formula, we have something called as a OB mix. So we have oats and buttermilk combination, or we have raisins and figs which are soaked and blenderized, or we have pectin used where the stewed apple is juiced, I mean boiled, juiced, and then it is given, apart from the commercial formula what is available. And this has been told to all the intensivists that we will be doing this, because otherwise, first question comes that what another powder added for the patient. So the clarity is given, and it is a mandatory part for all enteral feed patients, and that works wonderfully actually.
So, Vaidehi, I'd like to add something to this too. Okay, so it's come quite often to us when we have a patient on diarrhea, that you bulk up the stool using natural products. Now, when you are actually going to use natural products to bulk up the stool, what happens, unfortunately, what happens in such cases is that if you were to actually want to give 30 grams of fiber, you would need a hell lot of sugar and calories. That means to say that an average 30 grams fiber from a natural feed will actually amount to more than 900 kilocalories.
Yes, correct.
That is a problem, because what you would end up giving as sweet potato or whatever you want to give for fiber is going to add the calories. So what happens in the long run is you might tend to overfeed in the bargain of giving high fiber, especially when you're going to give it through a non-synthetic material like natural foods. That is one thing that is always a problem, because the best natural food also give you not more than 5 grams in 30 grams in
Agree,
30.
agree,
That's the real thing.
agree.
Hmm.
Especially in the blenderized formula, it is quite difficult.
Difficult, yeah.
Balance is always
And
important.
another thing also, no, another thing very important for us to also understand is, as a cause of diarrhea, our kitchen diet that comes in from the kitchens of the hospitals, you'll be surprised if you were to actually take their contamination. They are very often contaminated, and in those patients who are critically ill, that contamination is enough for the person to get diarrhea. In fact, there have been studies that have been, I mean, again, reported, which actually talks about contamination of feeds that come in from the kitchen, which actually causes diarrhea. So that's another important point that we should always think about.
Yes, yes. Especially for the
For
critical area, for sure.
for every 1,000 kilocalories, I think the recommendations are like 15 grams of fiber can be added for every 1,000 kilocalories that we are supplementing. For suppose if we are supplementing 2,000 kilocalories, so the soluble fiber can be supplemented at around 30 grams,
No,
per
that's
day.
that's exactly what I was mentioning, Akhilesh. If you were to actually take 30 grams
Yeah,
and you will take it from natural feed, you will
difficult.
anyways have 1,000 plus 1,000 kilocalories. This is what is going to happen.
That's not possible. So that's why we
Yeah,
should rely on the scientific food
yeah, yeah.
rather than the kitchen food or your natural food. Yes, natural food will definitely have a lot of taste and everything. But when the food is bypassed through Riles tube, forget about taste and all that. A critically ill patient will never be able to taste that natural food at all. He is not in senses as well. So that's why it is better to supplement through scientific formulas. Soluble fibers can be a good addition. But when patient becomes, well, then we
Recover.
can start supplementing natural food, natural fiber. I think that will be better off. But then we don't know whether that natural food really will be digestible or not. Some patients may also have constipation. Okay, soluble fiber are better off in that situation when the patient is recovering from the critical state of the disease. I think rather than insoluble fiber, the soluble fiber has a greater role to play when patient is recovering. And if the patient is absolutely stable, these insoluble fibers, can be added. Yeah.
So there are a couple of questions related to RT feed only. For those with long-term enteral feeds like rice feed, how to deal with them, and shall we give any fiber-rich supplements to rice tube patients? So I think we have covered those
Yeah.
both the questions. Okay. Good evening, sir. Doctor, restrict fiber in diarrhea. Okay, that was the answer given by you. Why? So most of the time, doctors say no fiber because patient is having diarrhea. So that is a question asked, and I
You
think
have to.
both of you.
You should be, as a dietitian, we should be in a position to give a proper explanation to the clinician because the
Huh.
clinician is always engrossed with his clinical outcomes, clinical recovery, clinical management, and in the bargain, he undermines the importance of the diet and the nutritional supplementation. So,
Mhm.
as a dietitian, it is your responsibility to educate your clinician as well.
Actually.
The clinician is not, well versed with the dietary formulas as well. In
Mhm.
most of the institutes, if you see it. So that's
Mhm.
why I would also like to say that as a dietitian, you need to empower. As a doctor, it is my responsibility to empower my dietitian, give her a free hand, give her a little space that she is able to explain, and she should not be burdened by your clinical jargon that you come up with, and your clinical management should not undermine the patient's nutritional requirement or the assessment. I think we doctor also has a significant role. We need to educate ourselves. We need to read and learn more about diet. We have learned about diseases, disease management, but probably we have not learned about the diet and dietary formulas and supplementation. There is a lot to learn. That message I would like to give it to you, somebody who has
Great,
asked this
great,
question.
great. Okay, next question is, during pregnancy, if patient is suffering from diarrhea, is it safe?
Yeah, it is. It is fiber is completely safe. It's nothing happens. Yeah. It is the
Okay.
only thing that we know about fiber now very convincingly is that it is very, very safe. So I just let me tell you something about this. So initially the problem with fiber in intensive care was because of the fact that there was one trial, just one single trial where they looked at chronic acute pancreatitis patients. In acute pancreatitis patients, they happened to give fiber, and what happened was some of them developed non-occlusive bowel necrosis. Okay, they developed non-occlusive bowel necrosis because the fiber was not digested and it caused it mesenteric ischemia. So this happened in around 6 patients in that particular trial of acute pancreatitis, and fiber got a very bad name. This is what occurred because in critical care, because of that pancreatitis kind of situation. But now we know that non-occlusive bowel necrosis on the whole has got an incidence of only 0.2%. Now 0.2% is very less to actually say that fiber is bad. The entire condition called as non-occlusive bowel necrosis, where there is gangrene of the bowel, occurs only in 0.2% of individuals. Okay, that is the reason that that particular trial should not be considered at any given moment. The only thing we know as of now is that fiber is the most safest thing now presently, and it is definitely not going to cause any harm.
Perfect. Next question is for obesity patients. How much fiber daily intake? So RDA for obesity patients.
I think we should stick to the guidelines,
Mhm.
as ISPEN and even ICMR also has come up. 40 grams is was what they have recommended, but it depends upon the caloric requirement of the patient. How
Mhm.
much calorie the patient is taking, and the fiber supplementation should be according to the calories that we are supplying and not according to the weight of the patient.
Right.
If the patient is consuming 1,000 kilocalories, even 15 grams of fiber, soluble fiber is sufficient. But it doesn't mean that if the patient is, obese, we end up and bombard them with lots and lots of fiber, probably it may not help. So it should be of a therapeutic importance rather than just a trial and error. And whatever we give to the patient, it should have significant impact on the overall outcome of the patient. So it's not just the fiber which is going to reduce the weight of the patient, but dietary modification, lifestyle modification, and then there are other factors, which I can't count on endlessly, because the other factors also should be taken into consideration while weight reduction is achieved. But yes, addition of fiber can be one of the factor which can help you reduce the weight, because when the fibers are consumed with the addition of the food, it increases the satiety and patient will never feel hungry, and he will eat less and he'll consume less calories, and as a result of which he will lose weight. So as a weight reduction strategy, along with dietary modification, lifestyle modification, and other modifications, the fiber can have one important role and help reduce the patient's weight.
The next question is old age patients. Is it safe to give 10 or 20 grams of fiber per day?
Yes, I think it is safe because elderly patients, they have digestion problem, they have absorption problem, micronutrients, macronutrients, electrolytes are not absorbed well. They will have perennial deficiency of potassium. They will have hypokalemia. They will have hypocalcemia. They will have hypomagnesemia, and lots of other important elements like selenium, zinc. These factors, these important elements are not absorbed from the GI tract. Simply addition of fiber will help the bowel to absorb these important ingredients, and the deficiency of these ingredients can be prevented just by addition of fiber. But yes, along with that, the dietary supplementation of these important elements are also very important. It's not just the fiber which is going to help. The fiber can assist in absorption of the dietary nutrients that we supplement. Okay, and it will also help the patient to recover better. But it is not the only treatment for elderly patients or obese patients. It should be an adjuvant treatment for obese patient or any critically ill patient. Yeah.
Can we take a few more questions, or how can we
And
do that?
see, these fiber have a significantly important role in reducing the insulin requirement, in
Hmm.
diabetic patients. I often see, I mean, Dr. Sanjit also must be seeing a lot of diabetic patients. They come up with very high insulin requirements. They will be consuming 30 units TDS thrice a day, 4 times a day, or something like that. So by addition of fiber, the insulin resistance can be prevented. First, the absorption of glucose can be enhanced. Sudden rise in glucose will be prevented, because if we don't if we give fiber deficient fiber, the food will try the glucose will be absorbed from the intestine very rapidly, and there will be sudden surge in glucose levels. And that sudden rise in serum glucose level will be sensed by the pancreas and the tissues, and they will try to synthesize insulin in large amounts to try to curb the elevated levels of glucose. And then when the large amount of insulin is released, later on this patient will go into hypoglycemia. So then we will keep trying one or the other anti-diabetic agent. We will keep titrating insulin levels, and in the bargain, the entire treatment will go and haywire. So that's why this fiber, addition of fiber also has a significantly important role as far as the control of diabetes and insulin requirement is concerned. I think it has a significant value. You would like to add, Dr. Sanjit? I don't know whether I'm right or wrong, but I would like to hear from you also as far as the control of diabetes is concerned. I think
You're
he's
muted, sir.
I think he's engaged somewhere else. Okay. Can we move on to the next question, please? Yeah.
Yeah. Okay. In prolonged rehabilitation neuro cases, how can we manage diarrhea by adding fiber, and what type of fiber?
I think this question is already answered. Soluble
Answer.
fibers and rehabilitation will not only include fiber. This is a discussion of fiber. It doesn't mean that fiber will be the primary source of energy, calories, proteins, or something like that. Fiber will be an adjuvant to the protein and fat or carbohydrate supplementation. So we should not just neglect the improvisation, and patient should receive uh, protein and fat and carbohydrate supplementation in the titrated amount when the no, depending and it's not just supplementing the diet or nutrients, but the patient should also be able to utilize it. Patient will be able to utilize it only when he is doing exercise, he's working. Simply bombarding with the nutrients is not enough here to get the work done from the patient. Patient should get engaged in exercise. That holds true for elderly patients also. If they remain immobilized, whatever you feed, all these carbohydrates, proteins, fats are not getting absorbed. Okay. So addition of fiber will help absorption of these nutrients. And the patient, if he does exercise, there the sarcopenia and other factors will also improve.
Sir, can I just answer this question also?
Yeah.
So chronic constipation is a very uh, different anomaly. It's a different disease on the whole. So when you say chronic constipation and chemotherapy induced constipation, they're very different things compared to acute constipation that we face in intensive care. So in chronic constipation, it's usually that the diet is itself not okay. The diet itself is not okay. That means to say that they may not be taking whole grains, whole wheat bread, pasta, oatmeal, legumes, fruits, berries, apples. These are not things that they take regularly. So they don't have regular fiber in their diet. And at that time, one of the most important fibers that have been shown in chronic constipation to have done wonders is psyllium. So psyllium is something that can be done, which is isabagula husk, which is basically isabgol. That is supposed to be one of the best and most tested fibers when it comes to chronic constipation at a dose of at least 10 to 15 grams per day. Not only that, and as Akhilesh really mentioned, very importantly, exercising most of the days of the week and regular physical activity in chronic constipation is known to work much better than even a dietary modification. That is the reason that exercising and drinking plenty of water would be something that will help.
Correct. Thank you so much. What is the difference between partially hydrolyzed guar gum and resistant maltodextrin, and what are their individual indications?
So, resistant maltodextrin is the one that actually gets 10%. It remains at the end of the day. Only 10% is hydrolyzed by the time it reaches the gut. So, 90% of this is available at the end of the day. This resistant maltodextrin is something that will have a slightly lower viscosity than guar gum, which is partially hydrolyzed. Partially hydrolyzed guar gum has got a much higher viscosity, and that is the reason that that holds water a little bit more than resistant maltodextrin. Otherwise, there's not much we can think between both of them. And this treated resistant maltodextrin has been proven in a large number of studies to have done both the things for constipation as well as for diarrhea.
Okay. And sir, would probiotics and soluble fiber help in management of diarrhea in ICUs?
So fantastic question. So this question is actually the right thing to do in medicine. So when we are talking of fiber, we're just talking of one arm of the entire story of trying to bulk up the stool. The other part of the story is we want to change the microbiome, the pathobiome to a microbiome. You understand? The gut microbiome gets converted to a pathobiome within 6 hours that the patient gets into the hospital. So the moment the patient gets into the hospital, gets one antibiotic, just one antibiotic, the gut microbiome completely changes. And you move from very good bacteria to almost no bacteria or to very bad bacteria. So Proteobacter comes higher than the Bifidobacterium and the Proznitsky bacteria, which is there supposed to be there in the colon. So when you add a probiotic, can we get a probiotic? When you add a probiotic to this particular supplement, in addition to a fiber, the benefit is supposed to be much better than fiber on its own. So there is no doubt about it that the addition of probiotic at the doses, the recommended doses, along with the fiber, would be better than the fiber on its own.
Soluble fibers like this resistant maltodextrin, it has some prebiotic efficacy.
Yes.
So,
So they
but
are prebiotics. They are prebiotics in the first place because they actually help to get these bacteria back from the pathogenic bacteria to the microbiome, which is bifidobacterium and Proznitsky bacteria. These are the things that will get back. Yeah.
and
But
it
addition of a
preferentially,
probiotic will probably be a better option. That's the study was actually based on wheat bran fibers, wheat bran plus probiotic versus wheat bran on its own. This study was done around 6 years ago. Beautiful study and a very large study also. They looked at people and they gave them wheat bran, which is very difficult to eat. Wheat bran is like you can't eat it. It's very horrible. The taste is very bad. So wheat bran along with probiotic versus wheat bran, and they found these patients who had wheat bran plus probiotic did better than those patients with respect to the stool frequency, stool consistency, stool evacuation, even incomplete evacuation is better when you're actually dealing with the combination of fiber plus probiotic.
yeah, preferentially these soluble fibers, they preferentially allow the overgrowth of non-pathogenic bacteria, and it inhibits the growth of these pathogenic bacteria. And that's how, it maintains the microbiota of the intestine, which is hampered by the usage of antibiotics or the disease state that the patient goes through. And it is these commensals, okay, these organisms, these non-pathogenic organisms, which are responsible for maintaining the health of the gut. And it has a preferential role. The soluble fibers have a preferential role in helping these non-pathogenic bacteria to grow more, especially these bacteria like Bifidus, you know. So these bacterial overgrowth will help to maintain the absorption and maintain the integrity of the bowel. Yeah.
What is the definition of diarrhea? 10 or more watery motions or 3 or 4 loose motions after long constipation?
So I
6.
think we should stop. We'll take last question. This is the last question, and we should stop because time is too much
Yeah,
over
we are running
because
short
it
of
is
time.
9:20
Okay.
till now, and
Okay.
still the participants are too much. Participants are still present. We reach at 240 participants today.
So it depends upon the disease condition, probably. So 4 to 5 stools is not really a matter of concern. But if even 4 to 5 stools is causing uh, you know, uh, clinical derangement, so that is considered significant. Even patient who pass 6 to 8 or 7 to 8 uh, loose motions, it doesn't mean that the patient has diarrhea. Okay, so by addition of fibers or other nutrients, if the patient is passing stools where the consistency of stool is loose, it doesn't mean it is pathogenic. The pathogenicity is decided by the clinical deterioration. If the patient is becoming, dehydrated or there is significant volume loss and causing any derangement in the hemodynamic status of the patient, probably that can considered as a significant diarrhea. But if there is, enough intake from the patient is hydrating well, and the patient is in a position to eat and drink well, it's just simply consistency of the stools which is loose. It doesn't mean patient has diarrhea. So there are different books which mention different frequencies to be considered as diarrhea. Some books maintain more than, some books mention 6 to 8 diarrhea. Some books mention more than 10 loose stools. Okay. It depends upon patient to patient, and the clinical profile of the patient will also decide whether the diarrhea is harmful to the patient or it is not harmful to the patient. Dr. Sanjit, you would like to add on this?
Yeah,
Because
so
different difference
I'll
of
just
opinion.
I'll just
Yeah.
finish this by saying the diarrhea, is one definition that has not been really defined, very well. In fact, diarrhea has been defined as various scientific groups and various health institutes by very different kind of definitions. But yes, if you were to actually define it for an epidemiological purpose, for example, you want to figure out whether there is diarrhea in because you gave a certain drug, then the definition would actually say more than 3 watery loose stools in 24 hours. This would be the real definition. More than 3 watery loose stools. And when I say watery loose stools, we are looking at something called as the Bristol stool criteria, which actually says that the stool should actually take the form of the container. If the stool takes the form of the container, that is called as a watery loose stool. And that's Bristol stool criteria 5 or 6 is what it basically means. There's something called as a Bristol stool criteria. So that's the actual definition for diarrhea. But I do tend to agree with Dr. Akhilesh that he says that it should cause something pathological. Yeah. So if you cause something that is pathological, it's that is called as definitely important and severe diarrhea or significant diarrhea is what I put it as. But this is the definition for diarrhea.
Thank you so much. Just last question I'll take. In 8 months, baby peg feed severely constipated, which source of fiber is recommended?
Which source of fiber for?
For 8 months, baby who is on peg feed.
Oh my God. So first of all, the dose of fiber is all not very evidence-based. Please understand this. The dose of fiber is not evidence-based. So if you look at different criteria, you will get different doses. So it goes right from 15 grams to 40 grams. So there is no specific dose for diarrhea. So there are certain fiber doses that are set from children to 1 to 3 years. What is safe is 14 grams from 1 to 3 years. Less than 1 year, there are really no guidelines. And what I'm quoting is also just recommendations from expert committees. They are not really evidence-based recommendations. That's why if you look at ISPEN guidelines, they will say 25 grams. You look at ICMR guidelines, they will say 30 grams. You look at other guidelines, they'll say 40 grams. So it has gone from 10 grams to 50 grams. But on an average, I can tell you that evidence is there that in 1 to 3 years old, up to 14 grams is not a problem. But that doesn't mean the dose is 2, 10, 5, 7 or 14. We don't know the exact dose for that. And that is why what we say is use as you go. That means to say use it and see what happens, then change the dose as time goes. And that's what we do in our ICU too. We actually give the dose and we see what happens, and then we accordingly adjust the dose. It's a titration when it comes to fiber.
Dr. Sanjit and Dr. Akhilesh, thank you so much for such a insightful and interactive session. Thanks a lot. Over to Dr. Jairam.
Thank you. Thank you. Thank you.
Thank you, Akhilesh sir, for such an excellent presentation and very informative session. I would also like to thank to the ISPEN for allowing the Mumbai branch to conduct such a educational webinar. I would also like to thank you to the Hexagon Nutrition for sponsoring this educational session. We'll also expect from the Hexagon education session, Hexagon Nutrition for further such educational event in the future of the Mumbai branch. Thank you to the Dr. Sanjit sir for the becoming as an expert as well as for allowing us to conduct this educational activity. Before ending this session, Hexagon Nutrition want to play a small corporate video. Over to the Hexagon Nutrition.
Jaram, before you forget, when is the next webinar? Can we please let all the audience know when is the next webinar?
So next webinar is planned on 2nd of the August in the evening time only 7 to 8 p.m. that will be on the use of glutamine in the ICU.
And we had 240 people registered today, isn't it, for the entire event? Yeah.
Yes.
So, Hexagon, over to you. Thank you very much.
So thank you once again, sir. And it was a very wonderful session, and especially a new topic of fiber. And thank you, ISPEN, for allowing us this opportunity to take up this topic for this session. And with this, I would just like to share a video.
Nutrition, a catalyst for robust health and longevity of life. The overall market for micronutrient premixes is set for a high growth trajectory in India. We at Hexagon Nutrition Limited are the only holistic nutrition player to offer products across 3 verticals: clinical nutrition, micronutrient premixes, and therapeutic food.
Since we have the entire nutrition portfolio under one roof, we are able to develop customized premixes and products with agility, cutting-edge R&D and analytical abilities.
As a fully integrated company, we are engaged right from product development to formulations, including research and development, manufacturing and marketing, with a focus on quality. We believe that R&D is critical in maintaining our competitive edge. Our R&D team strives to identify and develop new applications, combinations, and dosages of active nutrients with beneficial health effects in order to increase our product portfolio. We operate from 3 manufacturing facilities: Nasik, Chennai, and Thoothukudi. Our manufacturing facilities are strategically located in close proximity to the ports. Our products have been exported to over 70 countries worldwide. We have established 3 international offices in South Africa, Uzbekistan, and Hong Kong. Having started our business in 1993 as a micronutrient formulations player, we have moved up the value chain to develop our brands Pentasure, Obesigo, and Pediagold. We are a pioneer in micronutrient premix formulations business in the South Asia and market leader in customized and staple premix formulations in India. We have pan-India omni-channel distribution capabilities, supported by our presence across retail pharmacies, hospital networks, prominent e-commerce players, online pharmacies, and our own websites to address different consumer demands. Over the last 28 years, we have established long-standing relationships with marquee domestic consumer companies and global customers. We stringently adhere to compliances of environmental protection, corporate governance, and corporate social responsibility. Over the years, we have garnered a number of industry awards. We are led by professionals turned entrepreneur promoters with experienced management team. Hexagon Nutrition Limited. Nutritionally yours.
Thank you, sir, and thank you everyone for your patient listening. Thank you.
Thank you very much.
Thank
See you
you.
then.
Thank you,
Bye-bye.
everyone. See you next time. Thank you. Thank
Yes,
you.
thank
Thank
you.
you very much. Good night.
So
Good night.
thank you, Vaidehi ma'am, for moderating such a session, wonderful session. And with this, we should leave the meeting and we end. And you just remember our next webinar on 2nd of August, and we will give the next schedule in the coming days. We have a lot of planned activities in future time. Thank you. Thank you.
Thank you.
Bye-bye.
Thank you.